Hello, this is Jose Pascual from Philadelphia. Is Dr. Salamea the co-moderator on the line? I'm sorry, I can't show my image.
Okay, so I think Jose, I think we should we can start now.
Do we have our co-moderator with you?
No, he's not here.
That's what I was asking.
Salamea is not here.
Okay, so
I think we should start. We only have 1 hour, very tight.
Very good. So everybody, welcome. There's been issues with security in the past, which is why the security involves a lot more processes to sign in. My name is Jose Pascual. We co-organized this with the AAST and the Pan American Trauma Society with Antonio Martos, who should be joining us. He's also joining from overseas. This is a collaboration between the two groups following in the footsteps of the PTS, who has been doing this for 13 years. Today's panelists will be introduced shortly. The moderators are Dr. Guo, the chair of the International Relations Committee for AAST, and Dr. Salamea, who will hopefully show soon. Dr. Guo.
Okay, so in this 1 hour session, we'll journey through two interesting trauma cases from hospitals across the world, and each presentation allocated only for 25 minutes. 25 minutes. This also includes time for discussion. These cases will explore the creative and diverse approaches to trauma management, using local resources and addressing the various challenges in trauma bay in the operating room or in ICU. And our panel of trauma experts will then offer the invaluable insight and pearls of wisdom. And we are privileged to have three distinguished panelists today among us. Dr. George Vilmahos. He is a professor of surgery from Harvard Medical School and the chief of division of trauma from the Massachusetts General Hospital. Dr. Michael Eklund, he's a senior consultant surgeon and head of emergency surgery and trauma from Skåne University Hospital, Malmö, Sweden. So do I say it right? With a Swedish accent.
Perfect.
And we also have Dr. Philip Vega Rivera, associate professor from National Autonomous University of Mexico, the Hospital Angeles Loma, Angeles Health System from Mexico. Without further ado, let's dive into our first case. Will be presented by Dr. Sheng Yu Chang, attending surgeon from Linkou, Chang'an Memorial Hospital from Taiwan, with senior faculty Dr. Chen Hang Liao, professor of surgery at the same institution. Dr. Chang, go ahead.
Okay,
I'm sorry, hold on 1 second. Dr. Salamea is here, right? You want to introduce yourself?
My name is Juan Carlos Salamea. I am from Ecuador. I am a trauma surgeon, and I will do as a moderator, join with Alan Hu. This is amazing time to join people from American Association of Trauma and Pan American Trauma Society. I will enjoy a lot with these both cases presented today.
Okay, great. Dr. Chang?
Okay, let me start sharing my case. Thank you, moderators and doctors. Thank you for your time. Today, I'm going to talk about a case with liver and mesenteric injuries. And this is a 20-year-old male who just sent to a local hospital after the accident, and he fell off his bike around 3 a.m. That's 3 hours after, before he presented to our hospital. And initially, he complained of abdominal pain and he denied loss of consciousness. So it's very clear, but he's drunk and agitated. And the primary survey there at the local hospital, they told us that there's no problem about airways. There's no neck swelling, no hoarseness, and he's using oxygen mask with saturation around 99% to 100%, and breathing sound and thoracic movement are all symmetric, and the breathing sound is audible. However, there's a hypotensive event. They report blood pressure around 90 millimeter mercury, and the heart rate was 120. and his conscious is clear but agitated, and he's moving all his limbs. There's abrasion on the left upper abdominal wall, and there's some laceration at chin, and right leg is about 5 centimeters. And initially, they gave him just a normal saline transfusion, and they do the whole body CT. In Taiwan, there's not really too much trauma surgeons around the service. They're mainly provided by the images. Yes, sure.
Dr. Zhang, can you stop for a second? So
Okay,
when
sure.
The patient presented with hypotension. So we started with 2 large gauge IV. So I want to ask the panelists, what would you do here? Would you give a patient blood, and you give a patient red blood cell, or give a patient whole blood, or you only give a patient crystalloid?
Yeah, the answer you're seeking for is of course blood. The patients usually are bleeding blood in trauma, so yeah, blood would be preferred.
Yes, yes.
Yeah, I agree totally. There are a few elements that are missing, and Dr. Chan very correctly said that there's no trauma infrastructure probably in this hospital. But you know, you would want a fast exam to document that there is bleeding, or a chest X-ray, things that can be done within a few minutes to start thinking seriously about blood. I point out that in blunt trauma, sometimes on an otherwise totally fine patients, hypotension happens for other reasons but bleeding, and you would like to avoid 2 or 3 or 4 unnecessary blood transfusions. And this can very easily ruled out by a chest X-ray, a pelvic X-ray, and a fast exam. And if any of these 3 show evidence of bleeding, immediately blood for the hypotensive patient, preferably whole blood. If these 3 things do not show evidence of bleeding, the clinical exam also shows no evidence of fractures, major reasons for bleeding, then the blood transfusion should be reconsidered.
Dr. Rivera?
I'm totally agree that the first vision of the clinical case is to see what happens with the mechanism of injury, if they are probably some sources of a major bleeding that it's not right now. I'm coincide totally with Dr. Bulmajos about to rule out the pelvis and the thorax and also the abdomen. If you see any kind of liquid or fluid in this FATS exam, that is a very quickly tool to discharge anything there, you can consider the blood later if the shock persists, or you have another source of bleeding.
Dr. Chang, it seems that you even did not have the chest X-ray. Did you have it before you sent the patient for CT?
They didn't bring the image. So after they transfer the patient here, they only bring the CT images. So for the clinical sequence, so I just present their CT scans.
Okay, go ahead.
Okay, so after they complete this CT scans, there's liver and spleen injury according to their report, and the blood pressure began to drop. So they just use the blood transfusions and use PEG RBC4 unit. However, the 1 unit of blood in Taiwan is made from 250 millimeter in whole blood. So it's much lesser than the United States. And after they stabilize the patient, they just transferred it without any like endotracheal tube or anything, just with the IV set. So he came to our emergency department around 6:20. So there's 3 hours after injuries. So we just redo the primary survey. So the airway is patent, and the oxygen is very fair, and there's no signs of hemopneumothorax according to our fast scans. And however, he still experienced hypotension with blood pressure around 80, and heart rate is 120, and pelvic stable. And we did perform the fast scan, and there's a fluid accumulation in the Morrison pouch, which we already know because there's spleen and liver lacerations. And coma scale was 15, and the pupil was 3 millimeter reactive, and there's no obvious deformity of his limbs. And they sutured the laceration, and there's no more bleeding. And since he still had a hypotensive event, so we gave him a large bore IV set from the right subclavian vein. So and give him 4 units of leukopore RBC and 4 units of plasma. So here is his CT scans. Let me show it here. Wow. After review it, so there's no injury in the thorax. There's no hemothorax. However, there's obvious hemoperitoneum with the liver laceration at segment 6 and some bowel injuries. And there was a little bit contractile fractation from the mesentery, but there's no pelvic fracture seen in this
Before we discuss about the liver and the spleen injury, I want to ask the panelists, if the patient is persistent hypotensive, would you take the patient right to the OR, bypassing the imaging study? Or can we do something like Reboa or some other something to treat the patient at this point without a CAT scan?
Well, obviously, if you are in environmental that is, you don't have any resources, maybe the best chance, if you cannot transfer this patient to another facility because of the hypotension, and maybe the best option you have is to go in and to PAC. We don't have here in the country, because of our licenses, we don't have the Reboa yet. Even we have another catheter, that the Coda, but the Reboa, that is a small French, we don't have it here right now.
Dr. Eglund?
I would say Reboa, the scientific data today is so-so for Reboa. There is quite a controversy of Reboa. It might delay emergency department Reboa. Probably there are other opinions, but we don't use Reboa. And it would be an idea to take the patient directly to the OR and do the reprimer survey in the OR, having the report of being down as low as 16 systolic blood pressure.
Dr. Boba, how do you know there's no pelvic fracture, open book fracture causing the hypotension?
But by pelvic film. So I will answer your initial question under the understanding of this particular scenario, in which the original hospital had no surgical capabilities, as it often happens around the world and in the United States, and then the patient must be transferred. If you have no surgeons, you have no surgeons, period. So whether the patient is alive or dying, if you have no surgeons, you have to transfer the patient. But once the patient arrives to a point of definitive care with surgeons, and the patient after 4 units of blood remains hypotensive and tachycardic and has an identifiable site of bleeding as shown by a positive FAST, I think anything else but taking this patient to the operating room immediately is not the right way to manage this patient. No Reboas, no angiograms, no CAT scans. This patient has a blood pressure of 70/40 after 4 units of blood. The next pressure may be 40/0. So this patient belongs to the operating room as soon as this FAST is positive and the patient remains hypotensive.
All right, Dr. Chang.
Okay.
Continue,
Okay.
please.
Yes. Thank you. Absolutely. So, after he came to our emergency department, we just arranged the operation. So we sent the patient to the operating room within 30 minutes, and these images are just a review. And there's a lab show here. It's available acidosis, but there's nothing worth mentioning. Just a patient with shock. And for this injury summary, so we just take him to the OR, so as discussed before. Here's some pictures after the injury, after this operation. So you can see the picture on the left upper quadrant. So their liver laceration at segment 6 did not bleed so much, so we just pack it. And there are several mesenteric injuries. So we do the bulb resection, and there's a colon impending rupture, so we just resect it as well. So here's the summary of the operative finding. The operation take 2.5 hours. The total bone loss was 1,500 millimeter. And the blood perfusion intraoperatively is for only 4 units and 4 units of plasma. So here's a summary of our findings. So we do the suture ligation, and there's a perforation about 3 centimeters at the proximal jejunum, and the segmental ischemia at distal ileum. So both are resected. And there's mesenteric laceration and serrature at the descending colon and T-colon, which is repaired. And we resect a segment of sigmoid colon since there's impending rupture. And we pack the liver and use a temporary abdominal closure, then take the patient to the ICU. And during this operation, the blood pressure was around 90 and the heart rate was about 100. So it's fair, and there's urine output about 250 cc. So which vital sign is good, and we leave the operation room without bleeding. However, here's the vital sign after he returned to the ICU. So I think.
Ask a question first. Did
okay.
you start initiate the massive transfusion protocol in in the OR?
We do have the kit. We just deployed the kit right after he entered our emergency department. The massive transfusion set and the blood pressure, massive transfusion protocol in our hospital consists with 6 units of LPR and 6 units of plasma and 12 units of platelet once for one package. So the amount of blood transfusion did not reach the criteria of our massive transfusion protocol here.
May I ask a question? I didn't notice
yes.
what happened to the spleen.
After the review the image, there was no spleen injury, and during the operation we checked it. There's no spleen injury.
Dr. Bob Mahos, you're gonna take the patient to angio after you pack the liver. Next.
That's a very good question, actually, and I'm sitting on the fence with every such case. It will not be an easy black and white answer. I will examine how good my packing is working, and if it's not like totally hemostatic, I would definitely take the patient to angio. I would assess what type of an injury it is, and if I think it is a big, very difficult to access injury, I would definitely take the patient to angio. If on the other hand, I have effective packing, totally hemostatic, with a patient who's very labile and would much rather be in the ICU for the next 2 hours rather than in the IR suite, I would take the patient to the ICU. So it depends.
Dr. Rivera.
Yeah, I'm agree. The first thing that you have to do is to try to repack and to review your packing to the liver. The injury is a grade 2, so maybe you can even do anything more than just packing with that injury, and unpacking too, and to go to ICU first to maintain the patient okay first.
All right, Dr. Chang.
Okay, so for the next, after the patient get some massive blood gush out from the dressing, and the blood pressure began to drop. And that's about 30 minutes after he came back to our ICU. So we start the massive transfusion protocol and send the patient back to OR, since there's obviously some bleeder we missed at the first time. So for the second operation, we found that the bleeding was from the root of the SMA. But after exploration, we put some sutures on it, so the bleeding stops. And we checked the liver again, but there's only some mild oozing, mild bleeding. So we just pack it again. And we also packed the mesentery root, since we don't know if there's any other bleeder from the retroperitoneum, and with the abdomen covered with the negative wound pressure therapy. And this time the blood transfusion during the operation was 12 units of leukopore RBC, 12 units of plasma, and 24 units of platelet. And however, the bleeding still seems to be still a problem. The blood keep coming out and the blood pressure is still dropping. And we, since there's obvious something we miss, so we just do the CTA of abdomen again to check any other bleeders. Okay, sure.
You do the CTA, but I want to ask the panelists, at this point of time, will you do the CTA, or you just think, well, at this point of time, the patient is coagulopathic, bleeding, I'm not surprised to see the bleeding, because oftentimes when you take the patient over at this time, you don't see anything. So what would you do, the panelist? Dr. Eklund?
Well, I'm not an endovascular interventionist. We have proficient vascular surgeons that help us with the endovascular maneuvers, and they usually, if there is time, want CTA before going to the angio suite. So my answer is I prefer not to. But for anatomic checkup and maybe to find a bleeding, I would probably do a CTA before and take the patient to the angio suite.
Dr. Barhamos?
I can't imagine a worse nightmare than what Dr. Chan and his colleagues have faced. They've explored the patient twice. They've been to a very, very difficult area to access, the stem of the superior mesenteric artery, and the bleeding still goes on. And first of all, I want to congratulate them because they do all the right things. They give a balanced, massive blood transfusion. So congratulations, you do all the right things, but the patient continues to bleed. At this point, as much as my first impulse will be to go back to the operating room, try to find the bleeding and pack it, I would probably resist that in favor of going directly to interventional angiography. And this is why. The CTA of the abdomen helps the radiologist to localize the area that they should attack, so that they do not intubate the left internal iliac and the right internal iliac and the celiac axis and the IMA and the SMA and the what have you. They know what to target. But now they know what to target. They know that if there is bleeding, it is most likely 90% chances coming either from the SMA or maybe 10% chances for a branch of the hepatic artery. These are the two sides that they need to attack. And the CTA seems to me like it's only a waste of time. So I would go straight to interventional radiography, hopefully in a hybrid operating room, if that is available in your hospital. Have the angiographers rapidly access these two sides, embolize whatever they have to embolize, and then, you know, if they didn't control the bleeding, or even if they controlled it, I might reopen the abdomen in this operating room to repack it with fresh packs.
All right, due to time constraint, Dr. Chen, to go on.
Okay,
I
sure.
just have one question. At this
yes.
moment, what about coagulation? Fibrinogen
yes.
and the calcium
yes.
and tegrotum?
Yes. There's during this whole blood transfusion period, we do check the coagulation, but there's no thrombocytopenia. There's no prolong of the coagulation test. The PT and ABTD tests are normal. However, we do have the routine exam in our hospital, but in Taiwan, most of the medical stuff are provided by the National Health Insurance, but the routine is not. So we don't do the routine for this patient. Okay. For the CT of abdomen, we found that there's a pseudoaneurysm at the SMA, just maybe 2 centimeters away from the orifice of aorta. So our next step is we ask our IR team to deploy a stent. But before that, we just put a Reboa on zone 1 temporarily to make sure that he can do the IR intervention successfully. So here's the image from the angiography. So you can see there's a large pseudoaneurysm at the root of SMA. So we just put 2 stents over it. One is 8 millimeter and one is 5 millimeter. And after the stent coverage, there's no more bleeding, and I will show the video since the time is restrained, so I just skip the previous 2 videos. And after the stent is deployed, there's no more bleeding, and things like the bleeding stops from the abdominal wall. So we review his original CT. There's might be a small stent of the SMA root, just compared to the pseudoaneurysm we found from the CTA. So that's might be something we missed at the first time, but it didn't cause bleeding at the first operation, actually. So the further is quite smooth there. We take the patient back to the OR on the next day, and we check there's no more bleeding, and we do the bowel anastomosis on day 3. And he's extubated and his function clear, but however, it experienced some paraileus, and we're still treating him right now. And here's a case summary. So liver injury grade 2 and multiple mesentery injury and bowel injury and the SMA injury with pseudoaneurysm. And we will use a surgical and IR approach to stop the bleeding. And here's the end of my presentation. And thank you so much.
Great, thank you. I want to, yeah, it's almost 12:30. I want to ask the panelists, give us the pearls of wisdom as to how to pack the liver. How much pack do you normally do? 5, 6 lap pad, only 2 or 3? Because the pack it with too many lap pad, and after 24, 48 hours, you may have necrosis. We start with Dr. Eglund.
I try to realign the anatomy of the liver, and I pack it hard, as hard as I can until it stops. With sometimes mobilize the falciform ligament and to get packs around the liver, and yeah, I pack it hard. I've never seen ischemia of the liver due to hard packing, but maybe that's due to not enough numbers. And
Dr. Bob Mahos.
Yeah, actually, I agree with Dr. Ekelund. The trick is to pack the liver concentrically so that you bring it back together. And then once you do that, I don't mind how many packs you need, but you need to pack it hard. And similarly to Dr. Ekelund, I have not seen liver necrosis because of compression from the packing. And with that, I also want to take the chance to congratulate again Dr. Chan for the successful outcome of this case, the bleeding of which was not because of the liver, but because of mesenteric injury.
Dr. Rivera.
Thank you so much.
I just add that in some injuries from the liver, you can put stitches there, like an U, just to try to concentrate the parenchyma side with side. And the point is to try to pack, avoiding to compress the vena cava and the suprahepatic veins. Just in that point, and congratulates Dr. Chang for the extraordinary case. And maybe the other thing is we have to put more attention to the endovascular surgery procedures that can change a little bit the outcomes of these type of patients with surgery can be very difficult and very complicated to access and to try to stop the bleeding from that type of injuries. Thank you very much.
Thank you. Thank you very much. Excellent presentation. Dr. Salamea, you want to go for the second case?
Thank you. Amazing case. For the next case, I invite to present Marta Cudetis, trauma surgeon, and Pablo Helguera, surgery resident, 4th year from Panama. Go ahead, please, Professor Cudetis.
Okay, good morning or afternoon to everyone. First of all, I would like to thank everyone for the opportunity, especially Dr. Cudetis. I'm actually from, she's here in the back. I'm actually from Spain, but I'm actually in Panama for a couple of months learning trauma surgery. So this is a very nice opportunity for me. Starting with the case, we are going to present the case of a multiple gunshot wound and shock. And we want to present this case because some of the things that were done maybe weren't what everyone should say that's the correct way. But what we thought about the case is that maybe the discussion can be interesting for learning, as our experience actually was. So maybe it could be for everyone. To start with, the clinical case, a 27-year-old man that was brought to the ER in the Santo Tomás Hospital in Panama, the trauma center of the country. No previous medical history. And on arrival, he was shocked. I mean, sweaty, badly perfused, disorientated, a heart rate of 140, a blood pressure of 54/44, and a bad saturation, blood saturation. The analysis and ABCDE, there we was preserved. He was speaking actually about the ventilation, the breathing. There was the right type of ventilation with not the correct saturation. About circulation, he was clearly shocked, badly perfused, hypotensive, tachycardic. Neurologically, there were no deficits, Glasgow of 15/15, but confusion nerves. And about the exposure, we found several gunshot wounds, 4 anterior and 2 posterior, no lesions. When we checked the patient on arrival, there were 2 chest tubes placed. In the right one, there was immediate leakage of 2 liters of blood. So right after placing the chest tube, the patient was intubated in the trauma bay with ketamine and fentanyl, and massive transfusion protocol was activated. This is the image of the back of the patient, but in the right image, you can check with the crosses where the frontal 4 wounds were, 2 clearly in the thorax, and 2 that were in the lower part of the thorax, actually in the upper part of the abdomen. That's important because you will see it after what happened.
Okay.
So,
wait. Go ahead in the last one, please.
The primary evaluation.
Yes.
Oh, sorry. This one?
This patient is the gunshot wounds, multiple gunshot wounds, and he now is in the trauma bay. For the panelists, what do you think about what we can do if these vital signals and with this kind of gunshot wounds and the thorax and the abdomen? Please, any one of you or who want to talk? Dr. Belmajos, Dr. Ekun, Dr. Felipe Vega.
Well, the first duty is to to make the reanimation of the patient, put the 2 line boards in initiate a massive transfusion protocol, and if you obtain 2 liters from the right chest by the tube, maybe you have to plan to go to the OR.
Dr. Belmajos, what do you think about the initial management in the trauma bay or directly to the operation room, about the tubes and the initial management?
Oh, it's a difficult case. In my mind, there's only one question to be answered here. There's no question about fluids, about blood, about anything else. This patient clearly belongs to the operating room immediately, but there's only one question to be answered. Should you go first in the chest or should you go first in the abdomen? He's got reasons to go into the chest and in the abdomen at the same time. So what I would do after, I would call for massive blood transfusion and all this, but there would be 2 things that I would do very quickly, with the hope that I would get the answer chest or abdomen first. Number 1, a chest X-ray. I would do it very, very fast, in 30 seconds. I would do a chest X-ray to see whether there is any fluid on the left chest. I know that the right chest that has the chest tube, right, Dr. Martinez? It is the right chest that is bleeding?
Yeah, the chest tube were placed in both sides, but the bleeding was from the right one.
Right. So I know that there are 2 liters on the right chest tube, so I know that I must be on the right chest. I don't know what's happening on the left chest, so that would be clarified by a quick chest X-ray. And then I would do a fast exam, not because I really believe in the value of fast on penetrating trauma, but on this very case, if I found a big pool of blood on the fast exam, I would know that he's bleeding also into the abdomen. So with a fast negative and a chest X-ray that doesn't show me any blood on the left chest, I would immediately take this patient for a thoracotomy.
Dr. Ekelund.
And I totally agree. I do not see a clear point of doing the fast exam, and probably in reality, I would rely, if I have a large bore thoracic tube on the left side and I have bleeding on the right side, then I will probably rely on it not coming so much from the left side. And I agree with the thoracotomy and yeah, to proceed with also laparotomy. And the patient belongs in the OR.
I have a question for the panelists. Would you do ED thoracotomy? Number 1. Number 2, if you go to the OR, are you gonna do median sternotomy? Are you gonna go to a thoracotomy, left or right?
I would probably go for a right-sided thoracotomy, and then they go over for a clamshell if I don't reach it. But of course, sternotomy is a very good option. Then you have a full view.
Oh, it's a very good question, because if the liver or even the diaphragm is violated, you can have that blood in chest. So I concede with Dr. Belmajos that if you have the truth of is just also the thorax, you go to ER to the thoracotomy from the right chest. If you have the abdomen, you can do the both in the same time. Laparotomy and also with a thoracotomy.
One of the attendants commented and said the bleeding in the abdomen will kill him. And I say where he bleeds the most will kill him. So, yeah.
Go ahead with your presentation.
Okay, thank you very much. continuing in the trauma bay, the primary evaluation, the extended FAST showed no abdominal leakage, bilateral pneumothorax. The chest X-ray I'm going to show it right now, and about the gasometry, this was the basis. Acidotic, hypoperfusion. These are the X-rays. I mean, no other findings. I mean, knowing what happened later, if you check, we can clearly see the intestine, so that can make some information, but I mean, no those finds. And this was the chest one. This was after the placement of the both tubes. We can see liquid in the right one, not much in the left. So that's what the doctor said about the primary evaluation before deciding what to do. And I was given these options, but I think that all of you explained or discussed about them. So due to the initial findings, thoracic surgery performed an emergency thoracotomy, the right one. They found 2 more liters of blood in the right pleura. They were evacuated, and there were 3 lung lacerations that were shorted. When they exited the thorax, the patient wasn't bleeding from the thorax. After that, the patient actually didn't went out from the surgery room in very good conditions. That's maybe one of the discussion points of this case. And in the recovery unit, the patient was unstable. He was on 70/40 of blood pressure, tachycardic. He had a gross hematuria, and he was on pressors. So in the recovery unit, the next step, reassess the ATLS basics. What we see is that the patient was there, was protected, intubated, with good blood saturation, badly perfused, sedated, no external bleeding, but a gross and clear hematuria, and the blood gasometry wasn't better. I mean, still acidotic, lactate very high, low hemoglobin. So we found this patient in the recovery unit, I mean, right in 10 meters far from the OR. So we do an chest X-ray and fast with free abdominal liquid, a lot, and a chest X-ray where we can find, I don't know if it can be clearly seen, but a clear pneumothorax. Could be hypertensive because the right diaphragm was lowered. In this case, the X-ray was the chest tube was not connected to suction, so maybe that could be the case. So that's the patient we had in the recovery unit. So next management, I don't know, what do you do, doctors?
Pablo, did you note any injury in the diaphragm?
Not in the right one. I mean, during the thoracotomy, there were no injuries in the right diaphragm.
I would not leave the operating room with that low blood pressure and those bullet holes. So I would have done a laparotomy, and maybe it's just me, but I don't rely in penetrating injuries. I don't rely on the fast scan. It might give false security. And if you have gunshot wounds to the abdominal cavity, I would explore it just by the holes and the patient not being fully recovered when leaving or when thinking of leaving the operating room.
In this case, maybe laparotomy or laparoscopy?
In bullet wounds, laparotomy.
What is your opinion, Dr. Belmajos?
Well, this is a tough case, and you obviously pulled it through, so congratulations early on. But Pablo, I want to ask you a couple of questions. Number one, when you call the thoracic surgeons, did they do an anterolateral thoracotomy with a patient supine, or a posterolateral thoracotomy with a patient into the left lateral decubitus position? On the lateral side like this, or was the patient
was in supine, supine and anterolateral in supine.
Okay, all right. What would be the downside of doing what Dr. Eklund say? You had these gunshot wounds that were clearly below the nipple, so they could be through the abdomen. I don't think that it is reasonable to leave the operating room without making sure that the abdominal cavity is not violated. This is one. The second one, I have a second question for you. And it points out the difference between the subspecialists who do, say, thoracic surgery, vascular surgery, or whatever, and the trauma surgeons who know trauma. You said that the lacerations of the lung, they sutured them, right? These were bullet wounds. They were through and through lacerations, right? So explain to me what suturing means for a through and through laceration on the lung. Just explain to me, what did they suture?
I mean, they did. I mean, before answering, I didn't said it, but the point is that trauma surgery wasn't called. I mean, I think that's the first thing in this case. From the trauma bay, the patient was taken directly to the surgery room by the cardiovascular thoracic surgery.
Understood. Understood. So what does suturing mean in the lung for a through and through gunshot wound?
The lung parenchyma was sutured with continuous running suture of Vicryl for closing the. Yeah.
You mean, well, but you have the lung, and there's a hole here and a hole there, and a track.
Yeah.
You suture the one hole and the other hole?
Yeah.
Okay.
That's what they did. Yeah.
Okay. All right. So there is a track inside the lung, right? And you suture the two holes. And I'm telling you now that as soon as you do that, the patient becomes hypotensive and starts dying. The anesthesiologist tells you the patient is dying, desaturating, is hypotensive. What will you think? What happened because you sutured the two holes?
That the bleeding is staying inside the lung.
But you know, the bleeding, if that happens in the liver, you can do it, because then the bleeding will happen in the tract and the pressure will increase in the tract and maybe the bleeding will stop. But in this tract, there are open vessels. And what else is open in this tract beyond the vessels?
The tension of the breathing, the ventilation of the patient, because
exactly. The bronchi are open. Okay, so now you have a patient who's hypotensive, so the pressure inside the circulatory system is low, and a patient who's ventilated, and the pressure in the respiratory system is high. You close the tract, so this high pressure air through the air bronchus, which is injured, has nowhere to go but inside the vessel. What do you get from this scenario?
Gas embolism?
Exactly. You get a lethal complication. This is a no-no in trauma surgery. You should never do that. You can do that in the liver, but in the lung, if you have a through and through wound, you have to do a lung tractotomy, open up the tract completely and suture it individually, something that you almost never should do in the liver. But in the lung, you should never suture the two holes, okay? Remember that. And for this particular patient, the other than this suturing that it seems like he escaped from that, the issue, of course, is the abdomen. The abdomen should have been opened, like Dr. Eklund said.
Yeah. And I would totally agree, tracheotomy, either with clamps or a staple device. So you open up the tract and can oversue the staple line or so. And there was a question from Professor Salamea regarding laparoscopy or not. And I say, as one of the attendees said, never laparoscopy in an unstable patient. I would say to fiddle with laparoscopy when the patient has lower blood pressure, it's a no-no for me. So.
Yeah, I agree.
Good comment from the professor. We have a patient with gunshot wounds and initial management and the trauma bay, and then put the 2 tubes and go to operation room. Management with a cardiothoracic surgeon. I think this is the idea we have to stay in the mind. This kind of patients will be management with a trauma surgeon. And then we have a trouble in the thorax and also in the abdomen. Go ahead, Dr. Helguera.
Okay. Yeah, so I agree with everything you said. That's the point. I mean, here when we entered the case, when we started managing the case, was in this context, when the patient was unstable after the thoracotomy. So what we did was taking him directly to the OR. An exploratory laparotomy was performed. We found 2 liters of hemoperitoneum, a grade 1 hepatic lesion in the left lobe, not actively bleeding, grade 2 enterogastric lesion, a single hole of the bullet, jejunum perforation of higher than the half of the circumference, 10 centimeters distal to traits, a perforating lesion in mesocolon with no colon injuries, a grade 3 spleen injury, a grade 5 left kidney injury of the ileum, and 2 perforation in left diaphragm, not very big, of 1.5 centimeters. Just some scans of the lesions that I said. What actually was bleeding actively when we saw was the spleen and the left kidney, the left artery and vein of the kidney, and the jejunum. So what we did in the surgery room was first the left nephrectomy, then the splenectomy. We did hepatic hemostasis with simple sutures, no major things in the liver. Gastric suture, the same, no simple suture. A jejunum resection, obviously not anastomosis in this case. Diaphragm primary suture, and packing all the left retroperitoneum. We left an open abdomen with a Bogotá or Borra espacio. And the postoperatory management was in the ICU. The massive transfusion protocol continued. We used a TEG to guide the resuscitation. And 24 hours later, the patient was in very good condition, despite all the injuries he suffered. The acidosis was corrected, no coagulopathy, no noton pressures. So here we thought we discussed the case about doing a second look in this the next day after the surgery, or waiting 24 hours more.
Okay, this is a good questions about the resuscitation, and also I want to ask about the open abdomen management with Borraes or Bogotá BAG. Dr. Eklund, please.
So I have the discussion with the intensivists on all trauma cases. They're really eager for me to go back, and is something bleeding, is something leaking. But if the patient is stable and picking up temperature, coagulation factors, everything is looking good, I would prefer to wait maybe 72 hours to go back, to have the patient warm and in an optimal condition. What I have seen waiting 3 days is sometimes liver packs get really stuck to the underlying tissue and might be troublesome to remove. But I prefer to wait at least 48, preferably 72 hours if no suspicion of leakage or bleeding. That was the first question, and there was another question also. What was that? I forgot. Yeah. So I prefer to wait.
Vega, any comments?
Yeah, I'm also prefer to 48 hours to go in. I think in this case, Pablo, you wait 48 hours or maybe 24 hours if a patient is more stable to go and reconstruct the jejunum?
In this case, we took him to the OR in the next 24 hours. The next day he was taken. He was operated like 5 a.m. of the first day, let's say, and he was taken to the OR the 10 o'clock in the morning the next day.
Okay. Yeah, I think 48 hours could be a good option to go and reconstruct the intestine if you don't have any other problem or bleeding.
I don't have anything to add here. Same thing. Once the major resuscitation stops and the patient is relatively stable, he will never be totally stable. Then I would go in, whether it's 24 or 48 or 76, it will be determined by the patient's stability or instability.
I have a question from the audience, from Dr. Java. He was asking if during thoracotomy, a diaphragm injury was seen, would you repair via thorax and then you go for the laparotomy, or you leave the diaphragmatic injury alone and repair this injury when you are in the abdomen?
Whatever is easiest. But in this case, I would do the laparotomy 100% and probably prefer to suture it from the abdominal side. But if you reach it and can do it well on the thoracic side, I don't mind.
I think it depends. If the patient is unstable and you have to go to the abdomen quickly, it's better to leave alone and repair later by the abdomen.
Agree.
Yeah, same here. I mean, the diaphragmatic injury is the least of your worries. The important thing here is that you need to go to the abdomen. And then, you know, once you fix everything else, the last thing that you fix is this hole in the diaphragm. Whether you fix it from above or from below is whatever comes easier.
We don't hear you, Juan Carlos.
May I ask a question, or the question that I forgot was Bogota bag or not?
Yes, please.
We usually use a VAC, negative pressure wound therapy. When you use the Bogota bag, do you use it as a traditional Bogota bag without any suction, or do you have a low pressure suction?
We used it the traditional way, no suction.
No suction, yeah.
A good question. And in my mind, that if you don't have anything to you can use like Bogota bag as a traditional form, or make you put the back without any kind of suction because you don't need it. Just for a temporary closure, if you go in again to the OR and to make the anastomosis, maybe you don't need more than 50 millimeters of mercury of suction from the negative pressure back.
And if I have maybe intestines or I'm not sure about viability, and I have decided to go back the day after, then I might just suture the skin with the running suture, just to have it liquid tight.
Marcos, any comments about the Bogota bag of negative pressure?
We always apply negative pressure. I don't know whether it is an inappropriate cost expenditure in America. I think there is some benefit by keeping the tension of the abdominal wall so that you do not increasingly lose domain. So yes, we always use negative pressure, but you know, we spend money left and right for no good reason. So this may be another one.
Thank you.
This is an interesting question about retraction of the abdominal wall and the muscles. Were you able to close the abdomen? Because this is a patient you usually don't close because it's too swollen. How did you manage the abdomen? Could you close it?
We closed it. Yeah,
Yeah.
we did a primary suture and we closed the abdomen. Yes. It actually, the patient, I mean, one of the reasons we decided to make the anastomosis is because the intestine wasn't swollen. The patient, I mean, the abdominal tension was normal. I mean, it was actually pretty good. So we decided to do anastomosis. I don't know what would be your measurement. I mean, if you open the 24 hours later and if patient is swollen, the intestine is swollen, would you wait or even do the anastomosis?
Small bowel, I would just do an anastomosis.
Interesting. We also place a nasovaginal tube through the anastomosis. I think that's a very interesting point because we use it for early feeding. The second day after the surgery, he was getting fed by the nasovaginal tube. I think that's also an important thing.
Case, Dr. Helguera, please, the professors, can you do the last comments about the case? The old comments about the management of this case.
Okay. So, well, after what I said here, I mean, there was a primary hand anastomosis done, terminal, nasovaginal tube placed, and primary word suture. No post-operative complications. We started enterofeeding the second day by the tube, and the 10th day, the patient was discharged from the hospital, so it was pretty decent recovery. There were the chest X-rays after the surgery with good evolution, no pneumothorax, no hemothorax, and what I said, no complications, and the patient was discharged. About the take-home message idea, I think that in multiple wounded goods, we should never forget about the abdomen. In this case of shots, multi-field surgical management is possible. I think that in this case is what you said. The role of the trauma surgeon in these cases, I think, is very important. Even if the thoracic surgeon has to come to the hospital to do thoracotomy, that's another point. But I think that the trauma surgeon has to be from the beginning of the case, because if not, things that like this happen. That's, I think, one of the learning we should take from this case. That's the learning we took from this case. And I mean, an early second look is possible, is beneficial if the patient is fine. And the nasovaginal tube, I think it's a very useful thing also for the feeding of the patient. And that's everything. I don't know if there's any other question and any other the panelists want to say.
Comments, please.
Just want to congratulate you and especially the patient. Well done. Well, good outcome.
Yeah.
Likewise, congratulations on the management.
Thank you.
Good case, Pablo.
Thank you.
All right, well, thank you very much, panelists, moderators, and presenters. This concludes this June session. Thank you, everyone. Bye-bye.
Bye.